accept a transfer, they're very gracious and it's fine. But it does not exist in my area to have anybody go into a doc and have them give some sort of benighting of whatever it is. So it's transfer or do it. And it's something I've been doing for 35 years. I've been doing VBACs. I was at one of the first VBACs at out of hospital in California. And women are going to continue doing it, and we are going to develop another set of doulas or non-licensed midwives who are willing to attend unusual circumstance births if we forbid midwives. My informed consent is not like, oh, it's rosy. It's very comprehensive. And I'm sorry, this is something that's going to continue to happen in California. You're probably glad. And I hope that we can have good people who are helping these people to do these unusual circumstances out of hospital.
Faith Gibson, I just want to tell you that the last time I sent a client to Kaiser relative to a VBAC, they said that they would never, under any circumstances, ever say that it was okay for a VBAC to, that it was unlikely. In fact, they actually said that they wouldn't do that relative to any risk factor, that they were not in the business of prophesizing as to whether or not something was or wasn't likely, and they just refused to participate. So the Kaiser's a pretty big number of client in terms of numbers of families served. So I would suggest that we use the language that was in the previous standard of care, which had to do with very specifically identifying a previous one single previous low incision with, I think it said 20 months between babies or something like that. Thank you.
I just wanted to share in terms of birth intervals, ACOG does not attribute a higher rate of uterine rupture to short birth intervals. Rather, they say that there's a lower rate of VBAC success, but they do not risk out short birth intervals, and that's straight out of the 2010 practice guidelines. So I think that's really important to consider when we're talking about creating protocols. And then the second point I wanted to make was that the OBGYNs that I know personally and professionally who have either attended VBACs or have had VBACs themselves say that they would never sign off on a home VBAC simply for liability reasons, regardless of how supportive they are of women making that choice. They say they are happy to say something verbally, but they would never put anything in writing. So.
And our experience in our area, we had a hospital that did not do VBACs for many years, but they would send people over to UCD Med Center to be evaluated to see if they were okay for a vaginal birth in the hospital. And we had a lady who was about 4'9". All of her babies were over 8 pounds. She'd had 1 cesarean section, 2 VBACs in hospital, and now she was looking for, covering her bases and making sure that if we could no longer take care of her, she was okay to have a VBAC at our local hospital, the med center. And they told her she wasn't a good candidate for a VBAC, even though she'd had 2 already, because she was short and she had over 8-pound babies. They didn't take any consideration to the fact that she's a ultra-Orthodox Jew. She is planning to have 13 or 14 or 15 babies. That would mean she would have a number, maybe 10 cesarean sections. And in the intervening years, we have helped her with 3 or 4 more children. So now she has a total of 7 children. The first one was a cesarean section. Is she still a VBAC? She's had 6 vaginal births and 1 cesarean section about 13 years ago. Does that make her a VBAC still? When do you stop being a VBAC? When you've had 5 or 10 or 15? How many times do you have to prove that you're okay? Anyway.
My name is Diana Bayarta. I'm a licensed midwife in California here, and I want to read something from the International Cesarean Awareness Network. They sent a statement saying, the International Cesarean Awareness Network is in full support of women having the maximum amount of choices available to them when it comes to options in childbirth. ICAN is in agreement with the statement made by the National Institutes of Health, NIH, that, quote, VBAC is a responsible and safe choice for the majority of women with prior cesarean, end quote. As such, we believe that women should have the option to birth wherever and with whomever they choose. It is part of our mission to empower women to make these choices for themselves, and we fully support changes in the maternal fetal health care system that will support mothers making these choices.
Does the midwifery community or the OBGYN community have a definition of likely that you rely on when you're making decisions? So for physicians,
Not a
are you
number.
looking at, you know?
There isn't a number.
Okay.
It's certainly nowhere near 50%. I mean, that is just crazy enough.
So you're recognizing that the terms are probably different for attorneys versus
Absolutely.
healthcare providers.
We come in, we have this happen not uncommonly, and we know this because Shannon is an attorney. And so she will sit there sometimes and say to us, do you know that has a legal definition? And we're like, no. Do you know it has a medical definition? And they're like, apples and oranges. And so I'm not surprised that you have this likely word that means something to you that means something different to me.
So you're looking at something, so likely also encompasses the severity of the risk that it poses to the
Stakes.
client.
Yeah, what are the stakes? How high are the stakes? But I mean, and I would have to say that from a legal standpoint, it is absolutely true that an attorney who is filing suit against me is certainly not going to think, oh, well, it was only a 29% chance that this was going to happen, so it was okay. I'm not held to that standard by your profession when it comes to medical malpractice, because likely does not mean 50% when it comes to medical malpractice.
Except we have to prove it by preponderance, which is likely that you were negligent and that your negligence caused the injury or death. It has to be proven by more likely than not that that's what occurred. But I saw Diane. Do you have any comments before we got into that discussion? Just about what.
Likely.
Yeah. Okay.
No, I mean, I get the point.
Right.
Right.
In terms of informed consent in the midwifery community, I know that what I do is I don't say likely. I try to give women as much statistical information as I can so that they make their choices. There certainly would be things that I would say could possibly say to somebody, I cannot support that. I do not feel comfortable doing that. May I help you try to find another provider who would be willing to do that? The couple of times that I have done that, and I don't think I've only done that twice, the women have gone on to talk to other providers who say the same thing. And I think that repetition gives them impetus to realize that they need a higher level of care than what they have originally conceptualized for themselves. The whole thing of likely, it's amorphous. It's a really difficult thing. It's a concept. It's not anything hard and fast. So it's a difficult one, and I appreciate that.
So
I still think, though, that we need to keep on thinking about women's autonomy. And we have to support them in making their choices. I recognize what Shannon said about ACOG never wanting the waiver that we had in the original standard of care. But they agreed to it. And they agreed to it because we were trying to prevent women from having unattended births that are much more dangerous than having ones where there are skilled and perceptive professionals there who know what to look for and can say to a woman, this labor right now is not going well. And given that that's true, you have this history. If you didn't have a previous cesarean, we might stay home for another few hours. That's not what's happening here. You are in a situation where we now need a higher level of care.
Can
But it's got
anyone,
to do with autonomy.
off the top of their heads, give me a state where midwives can do VBACs without a prior physician consult?
Vermont,
Texas, New Mexico, Oregon.
Oh, yeah.
isn't Florida?
There is now only one state that requires physician supervision. There used to be two, that was us.
Right.
Now there's Louisiana. So the physician supervision
just in
is
general.
essentially a non-issue.
Yeah.
But as far as a physician consultation for VBAC, there are some states that require that. There are some states that do not allow CPMs, LMs, RNs, whatever they're called, in the state to do VBAC at all. There's very few. But of the largest of those subsets are the ones where the CPM, LMs can just do VBACs without a consult.
Okay, so let me make sure I'm stating the question correctly and then I get the full list for review. So states where there's no physician supervision of licensed midwives and they don't have to have a prior physician consult to do a VBAC at home. What are those states?
I would have to look it up, but Vermont, definitely. New Mexico, Oregon, Washington, yeah,
Texas?
Texas, Utah, I think, Wisconsin, I think.
What about Florida?
Florida may require a consult. They do allow VBAC, but they may require a consult. Alaska has some prohibition. I'm not sure if it's they can't do them at all or they require a consult. In Arizona, they cannot do them. It's regulatory, not statutory, but they can't do them. Anybody else? New Hampshire, just yes?
I think it is yes. I'm not positive.
Minnesota, I believe, is yes. But I would have to confirm most of these.
Okay.
There are some.
I think Idaho has no restrictions.
So, what we have to look at in our state regarding the outcomes of the care that licensed midwives deliver is the licensed midwife annual report, where we've been collecting data since 2007. Imperfect though it is, it does give us some information to look at. At 2 o'clock this morning when I couldn't sleep, that's what I was doing. And sections O and P of the LMAR list outcomes after transfer of care. So I think we could all probably assume that if a woman had a significant event related to a prior cesarean, she'd probably get transferred. So that's where I started. And it lists outcomes for both maternal and infant, including death. So I loosely drew the following conclusions. For those 6 years, from 2007 to 2013, there were 13,579 planned out-of-hospital births. Of those, most women delivered at home. Of the ones that were transferred, only a small percentage, 8% or less, had sequelae lasting past the 6-week postpartum period. That does not include deaths, that's just morbidity that lasts longer than 6 weeks. When you look at reasons why women were transferred that could be even remotely considered attributable to a VBAC emergency, they include things like adherent or retained placenta and hemorrhage of all sorts, or bleeding of all sorts of various causes. there were a total of 108 events. Okay? So even if we say all of those, which is unreasonable, had to do with VBACs, out of 13,000 women planning to deliver at home, that's a pretty small number of events. We can probably, since the main concern with VBAC is a uterine rupture, catastrophic uterine rupture that puts both mother and baby at risk. Fetal demises are not generally a consequence of labor, so even though there are a few of those, we can probably discount the majority of them. There were no maternal deaths. The only neonatal deaths that might possibly be attributed to VBAC causes would be those listed in Section P of the LMAR as other related medical condition, because the other conditions that are listed there don't really relate to VBAC. There is no category on the LMAR directly related to VBAC outcomes, which we might want to change. But in the years from 2010 to 2013, which were the only LMARs that I could pull off the web in the middle of the night, there were 2 neonatal deaths for those 4 reporting years. And there were no maternal deaths. During those same 4 years, 451 women with a prior cesarean section were delivered safely at home. That is the statistic